be speaking a little bit later. I'm an endocrinologist in Fayetteville. I have the pleasure of introducing Dr. Janet McGill in my lab now for 12 years. I actually trained with her at WashU. Dr. McGill is a professor of medicine at WashU, Washington University School of Medicine, and an attending physician at Barnes-Jewish Hospital in St. Louis. She is a leader in diabetes research and has served as a principal investigator on over 200 clinical trials, a couple of which I got to participate in, including major studies such as the renal and GRADE trials, NIH-sponsored trials. Clinically, she treats adults with diabetes and is recognized for her work in optimizing insulin technology and improving care for patients with atypical diabetes. She has received numerous awards, including recently the ADA Outstanding Physician Clinician Award and Master of Clinical Endocrinology with Distinction. She's an advocate also for better access to continuous glucose monitoring. She also has a lot of grandchildren and is very active and travels all over the world, and she's just amazing. Here's Dr. McGill.
How many of you treat patients with kidney disease? Everybody, everybody, some don't. How many of you treat people with diabetes? Well, one of the issues is that diabetes is a well-known provocateur or accelerator for kidney disease. And, interesting words. These are my disclosures. Patients put up with their diabetes. They do their best. They don't really appreciate getting kidney disease. It's sort of the disease that keeps on giving, and it makes it really tough for patients after they struggle with it for 15, 20, 30 years and end up with these serious complications. So kidney failure is becoming a major international issue, not just national. Lots of patients on renal replacement therapy, kidney replacement therapy. There are also many patients worldwide who don't have access to it. So they're what they got kidney failure. And international trials have to use renal death as a confounding factor for end-stage kidney disease because of lack of access to renal replacement therapy. Okay, so let's start about what's normal. We lose a kidney function during our lifetime. How fast do we lose it? We lose it without diabetes, without hypertension, just carrying on, without risk factors. The rate of loss of GFR is 0.5 to 1 milliliters per minute per year. So if you start at 120, you should be able to live 100 years and still have some kidney function left. That's the plan. Kidneys are still working. By the way, my dad turned 100 on Monday. And his GFR is 50-something. just other things are going wrong. But his GFR is pretty darn good. But he doesn't have hypertension. In fact, he can't keep his blood pressure. Disappointing. But no hypertension, no diabetes. eGFR is in the 50s, and he's 100 years old. Okay, what about diabetes? You have diabetes, doubles your rate of loss. You're now at 2 to 3.5 milliliters per minute for what rates out here meters square per year. And it varies now by how bad your diabetes is, albuminuria, other hypertension, other factors. But this is daunting. Our patients who develop diabetes at younger ages are really, they have problems. Rapid loss, what do we consider rapid loss? Rapid loss is variably defined as loss of either 4 or 5 milliliters per minute per year, depending on what source you look at. So what are the risk factors for rapid progression? Proteinuria is a known risk factor for rapid progression, which is why kidney studies are done in patients with proteinuria, because if we did that in patients without proteinuria, it will double the length of the trial. And no one wants to sit in a clinical trial for 10 years, so you want a trial to be done in 2 to 5 years. So these patients with proteinuria, elevated blood pressure, particularly systolic, heart failure, accelerant anemia, smoking, current or past smoking. And this comes from a Kaiser Permanente study of about 36,000 patients, 1 in 4 had diabetes, and were fast progressors. 1 in 7 without diabetes were fast progressors. They had other forms of kidney disease. So this is eGFR decline by albuminuria status. So type 1 and type 2 look very similar. Not terribly different. Normal, 1.9 milliliters per minute per year. I mean, this is depressing, right? Type 2, normal albuminuria, 1.9 milliliters per minute per year. Microalbuminuria speeds it up a little bit, but it's really the macroalbuminuria that really causes the accelerated loss of fluid function. Okay, then what happens? This is from the UK Biobank that tracks thousands of people in the UK. This is 12,000 people. These are adults with type 2 diabetes, without known cardiovascular disease or kidney disease. They just have diabetes. Okay, how long does it take those patients to develop chronic kidney disease? About 7 years. Okay, this is all comers. These are not newly diagnosed. So some of these will have it for a period of time. How long for heart failure? About 7 years. How long for atherosclerotic cardiovascular disease? Oh, about 6 years. Then what happens? Let's see, you have kidney disease, you have heart failure, you have coronary artery disease. This is how fast you go to the next problem. So if you have kidney disease, 0.9 years to atherosclerotic cardiovascular disease, or heart failure. Heart failure, 0.7 years, probably kidney disease. Atherosclerotic disease, 0.7 years to either kidney, and kidney disease is eGFR less than 60, and that's pretty darn common. So really an accelerated timeline for these complications. So what are the factors that affect CKD development and progression, and what are the targets of therapy? Well, glucose control, A1C. And if you would like to accuse endocrinologists of being glucose-centric, we will say yes, we are glucose-centric because it matters, and it matters if you start early. You can. Starting at 20 years will be helpful, but you know that horse is out of the barn. Hypertension, blood pressure goal, less than 130. ABA finally came around and lowered their blood pressure goal either this year or the last year. They were always stuck at 140 over 90. They've now lowered it to 130 over 80, and below 130 and below 80 is the blood pressure target. Use of RAS blockers. And the goal is the maximum dose. Now that 5 of lisinopril, you're treating the doctor, not the patient, with that. Okay, you know, start with 10, 20, 40, maximum dose for ARB, use of GLP-1 receptor agonist, SGLT2 inhibitor, and now the non-steroidal mineralocorticoid receptor antagonist. Okay, this glucose control matters a lot. You all are aware of DCCT, 6.5 years, A1C delta 2%, 7 to 9 basically. And then after 6.5 years, the conventionally treated group started MDI, the MDI group got tired of having hypoglycemia, so they all ended up at 8. This is with older insulins, figure 6 checking, it was tough. Some on pumps, but A1C is 8. And now these groups are equivalent after that. So equivalent A1Cs after 6.5 years. And what do we see? the intensively treated group had a 50% reduction of microalbuminuria, 50% reduction in eGFR less than 60. That initial 6.5 years that set up their glycemic memory, their glycemic legacy really matters. It is not okay just because the patient is, I don't know why we ask about symptoms of hyperglycemia. If you have symptoms, it's, if there's a problem, we need to treat this before the symptoms. When it comes to lowering trials in type 2 diabetes, advance, use new or worsening neuropathy, delta A1C is not that much, 0.67. The risk ratios, so similar to hazard ratio and the significance for any incident albumin DNDT small I study, wider A1C delta, poor incident microalbuminuria was their outcome in accord. All are significant with delta A1Cs, 0.67. I mean, it's not very much, 1.5, 0.9. Okay, just get the A1C down. If it's 80, get 7.5 or 7. If it's 8.5, just get it down. We can do that now. So the interaction of rate of decline in albuminuria after the onset of diabetic kidney disease. Here's the question. Once you have kidney disease, does it matter? So there's now been good data. We now have a study that is a reanalysis of the Curl study and the Parade study. As it turns out, you do progress faster with higher A1Cs, particularly above 8.5. That's the red here. There's more rapid decline of estimated GFR, especially if you're coteriorated, even if you have microalbuminuria. You get more rapid decline of estimated GFR. So even in patients who have kidney disease, it's still worth implementing better glucose control. What about blood pressure? This is a Korean study. All right, so the solid line of systolic blood pressure is greater than 140. This is a cumulative incidence of CKD. I'm just saying that I would rather have my systolic blood pressure here below 120 or definitely below 130. That's where I want to be. So that's where our patient should be. Diastolic, similarly, greater than 90, or kidney disease, everything else is better. So just get the diastolic below 90, below 80 is better. Okay, in the reanalysis of the court study using Sprint criteria, standard blood pressure control, less intensive was less than 140. They weren't much less than 140, after a little above 140, compared to less than 120. They were not less than 120, they were a little above 120. Intensive blood pressure control, combined cardiovascular outcomes, so you get non-fatal MI, non-fatal stroke, you'd rather be in this group. Okay, so get the blood pressure down. And it's sometimes a battleground of patients to take blood pressure meds, but it's worth it. And then we have this problem. I copied this slide from one of my favorite nephrologists that blood pressures are all wrong. I mean, it is hard to get with blood pressure. The correct way to take an office blood pressure is sitting quietly for 5 minutes. Has anyone tried to park in our plane parking lot? Our blood pressures are really high. It's just the way it is the most awful parking lot that I have ever been in. And then patients are rushing in because it takes so darn long to get in. And no one sits for 5 minutes. Unless they're waiting for me, then they might. Proper cuff size, bare arm, heart level, multiple measurements, average the results, and then check our standard blood pressure. Well, nobody does that. The other thing is watch your staff if you're still using a mercury manometer. I mean, my primary care doctor still uses the mercury. Then we watch it. It's like, where did you find that? They go so fast that there's such a jump between, heartbeats, that's not accurate, that's too low. We use an automated hub, which is what is used in clinical trials that reads quite a bit higher, and it is a problem. We have to be careful about cuff size. So really work with your, the things that you can do. This is a conference. Things you can do with your front office staff is measure height, measure weight, and measure blood pressure as well as you can. Okay. All right, these are the older studies, Rennell and IET. Look at the risk reduction, 16%. This generated all kinds of excitement in 2001 because we had the capital trial that had a bigger risk reduction, but this is type 2, 20% for IVAT. There is a huge residual risk. Here's another interesting, sort of factoid about ACEs and ARBs. So mortality goes up in persons aged 65 years if the dose of the RAS inhibitor is submaximal or if it's discontinued. These are drugs that we need to have on board. And this is true, this is all comers who have chronic kidney disease, stages 3 and 4. If you stop the RAS blocker, the mortality goes up. Submaximal dose, also higher than those on maximal prescribed dose. Use the maximal dose. Heart failure, huge difference. Maximal dose, or discontinued submaximal versus maximal dose RAS blockade. Diabetes, big difference. Okay, the at least triple, if not quadruple, between discontinued and continued. Okay, total population, same thing. So not only should we keep it on board, we should keep it on board at the maximum dose, maximum tolerated dose. Okay, we went about this whole phenomenon of stopping the ACE or ARB when the EGFR falls below 30. So the very common thing that's done. Is that correct? Should we? So I can't stop them from doing it. They're trying to eke out, 3 more milliliters per minute of eGFR. Well, you might eke out that little bit higher GFR from 18 to 20, but what happens? Survival is worse. So survival probability is better if you continue the ACE or ARB. Also, eGFR decreased 40% in the year is better. Fewer people progress to greater than 40% if you continue the ACE or ARB. Then continue it to write about renal replacement therapy. Granted, there can be problems with potassium that have to be dealt with, but survival and preservation of kidney function is better if you continue it. The STOP ACE trial, so this study started with eGFR just under 30. Okay, and looked at patients for the drop. This trial started with an eGFR 17, 18. So different, more severe population. So what did they find? They found that follow-up in 3 years. So continuation group versus discontinuation group, this is reaching an estimated GFR of 10. So we see no significant difference. They're not different. What does this tell us? It tells us that it's safe to continue the ACE or ARB. So this ends up being a non-inferiority study. If anything, the continuation group does, just a smidgen better, but not statistically significantly different. But the other finding is that it's safe to do so. So continue the ACE or ARB. We can do that much. Okay. So now after 2001, what happened? All kinds of things you studied in patients with kidney disease. One after another, and they all just sort of fell on the sword of either not being effective as rubidoxastorin, pirfenidone, which is the anti-fibrotic, sulodexide, which is a heparan sulfate inhibitor, Aliskiren, a renin inhibitor, caused too much hyperkalemia. It was the dual RAS blockade phenomenon. We've all been told not to do dual RAS blockade because of potassium problems. Most notable in this large aliskiren study, altitude, dual therapy with lisinopril, losartan, that didn't work, ferdoxolone, that didn't work either. Increased proteinuria and increased heart failure. Otherwise, it seemed to be good for kidneys, but I was looking to get some D for this study. I did this one. Just things just did not. I did this one, I did this one. It just did not work. It was pretty depressing. I mean, this went on for 15 years, absolutely nothing. Lots of efforts that you've not heard about because they were not positive. Okay. So what about the new thing? So what about our standard drugs, glucose-lowering agents? We talked about blood pressure agents, cardiovascular renal outcome. Well, we didn't have much to talk about, quite frankly. Everything was either, okay, get the blood sugar down. Didn't really add anything. Maybe metformin with no outcome data. Then all of a sudden we get a GLP-1 agonist that GLP-1 SGLT2 inhibitors. It's like came out of nowhere. Endocrinologists prior to 2015 in the Emperor trial, we thought the notion of keying out glucose was the dumbest thing anyone ever heard of. These drugs have been kicking around since the 1980s. And the thought that somebody would develop them for treatment would just struck us as just ridiculous. Nobody was ready for Amphobac, and it's been kind of fun after that. So LEADER, first GLP-1 study. What does it show? It shows that positive renal outcome hazard ratio 0.78. Well, this is stronger than the Arbitrage. Their hazard ratio was 0.86. So we now have a hazard ratio of 0.78, but it was led by progression to macroalbuminuria. They didn't really have enough patients to show the decline in eGFR. So it's some very suggestive. It was a secondary outcome. Yeah, we'll take it. Needs additional study. Did not happen with liraglutide because liraglutide has been replaced by once a week. Okay, what's the next study? The next study is Word 7. This is dulaglutide. This is a 1-year study comparing dulaglutide at 2 doses, 0.75, 1.5, compared to insulin. So now you're thinking, should we start insulin? These patients have an estimated GFR of about 35. And Kathy Tuttle was the lead author of this study. Well, what happens? What happens is it gets a little bit better with dulaglutide, it gets a little worse with insulin. And this is by cystatin, by AMA. So this is what happens. Be better with dulaglutide, worse with insulin, more rapid progression. Same thing with albuminuria. This is 1 year. So not an actual outcome trial, but it's very suggestive that the GLP drugs are likely to have beneficial effects on kidney outcomes. Okay, this is hot off the press. The McGill trial was presented at ADA. 3,500 patients, type 2 diabetes, chronic kidney disease, eGFR 50, 75, and race here greater than 300, less than 5,000, or eGFR lower with a lower level of albuminuria. Randomized, double-blind. The primary outcome event was eGFR decline greater than 50%. Okay, to put this in context, the old composite kidney outcome was doubling of serum creatinine. Okay, arithmetic, not questions here. So doubling of serum creatinine is about a 57% decline. So the 50% decline is pretty close. It's a round number also. People like round numbers. Kidney failure, deaths from kidney or cardiovascular disease, up to 5 years. It was stopped early, not too early. We're at about 4 years. This trial was done during COVID, which added a layer of complexity. First major kidney disease event, hazard ratio 0.76. Again, it's still better than Renal and IDMT. Okay, and these patients are on ACEs and ARBs. Kidney specific component of 0.79. So this was, this is pretty solid evidence that GLP drugs are good for people with chronic kidney disease. And not only that, no sustained SIDS, that they're positive cardiovascular outcomes. And they hit it again in slow, hazard ratio 0.71 for death from cardiovascular causes, like a comp. Here's all this BT stuff. EGFR slope, you can see that it's less with semaglutide, so reduction in progression. First major cardiovascular event and death from any cause hazard ratio 0.8. In this high-risk population, they did very, very well. Okay, so, the early outcome trials, these drugs were not necessarily indicated in patients with chronic kidney disease. So the early cardiovascular outcome trials had patients with pretty mild, they really didn't have kidney disease. Now we have SGLT2 trials, and they start looking at these more severely affected patients. They move from here to here with the credence down CKD out of kidney. So in the cardiovascular trials, there were not very many events. These drugs are so good that with not very many events, they were statistically significant. And now we do dedicated trials, and what do we find? First one was a credence, cannibals less than 100 versus placebo. They continued treatment if the GFR fell below 30. It's not really for efficacy, hazard ratio 0.7, 30% risk reduction. I mean, we're now into big numbers. These are huge risk reductions. Cardiovascular outcomes, hazard ratio, death, non-fatal MI, or non-fatal stroke, 0.8. Death for heart failure hospitalization, hazard ratio 0.69. I mean, these are big numbers. Diabetic Kidney. Diabetic Kidney was the first trial that enrolled non-diabetic patients. They had proteinuria, so their IgA, FSGS was something like 10 milligrams once a day versus placebo. EGFR now down pretty low, 25 to 75. UACR down a little bit at 200 to 5,000. Stable, maximum tolerated and legal dose ACE or ARB. They did not include polycystic kidney disease. Stopped early for efficacy. This has become a trend here. Okay, they use this 50% decline, end-stage kidney disease, renal cardiovascular death. I mean, we're getting almost a 40% risk reduction in a sort of a broad range of kidney function down to 25. Cardiovascular death, heart failure, hospitalization, hazard ratio 0.71, all-cause mortality 0.69. I mean, not only are these drugs indicated for these patients, these patients should be on these drugs. There's just not indefinite flows dose generic this year. So there will be even less reason to not use them. It requires some management. We have to manage the side effects, but we need to stop, one of the management issues is getting the A1C down so you're not on opening floodgates, so you don't have as many infections, that sort of thing. Get the A1C down to something else. These are not very good glucose lowering drugs, and they cause problems if you start them with an A1C of 9 or 11. If you get the A1C down to whatever else you want, GLP-1 being a good choice, and then put these on later. and you'll avoid a lot of problems. And the kidney, so they used a very broader group of patients with kidney disease, albuminuria if eGFR is greater than 45, and no albuminuria needed if eGFR is less than 45. So the enrollment, 20% did not have albuminuria, 34% had an eGFR less than 30. They all were above 20, so now we're down to 20. It's pretty low eGFRs. Okay, again, it's not really for efficacy. What do we see? In the use of 40% reduction, renal and cardiovascular cause, risk reduction 0.72 or about 30% in this broader population. Okay, primary outcome, diabetes present, diabetes absent, or it's a little bit better in those with diabetes, but either or. Estimated eGFR less than 30, equally good to those with eGFR greater than 30. So do not think that you have, everyone gets a little bit nervous when you get to stage 4 chronic kidney disease. Just treat it. Stop getting nervous and just treat it. Okay. UACR, what did not work well is when there's absolutely no albuminuria. These trials need to be longer for that group, so we just do not have data in those without albuminuria. There's no harm, but we don't see the benefit in that 20% group. Okay, meta-analysis, well, you can imagine if all studies are positive, the meta-analysis is also positive. Risk reduction of 36%. I mean, these are huge numbers. Okay, so despite RAS blockade and even SGLT2 inhibition, patients with type 2 diabetes and proteinuria is still at a residual risk. There's still a ways to go. So is there anything else we can do, we should do, any other new therapies? Along comes the notion of the mineralocorticoid receptor antagonism, so blocking the mineralocorticoid receptor. So why is this not dual ACE/ARB? Well, kind of is, but it's not exactly a dual therapy. So Fidelio, I'll tell you, there's a dedicated kidney trial using mineralocorticoid receptor antagonist. Turns out the mechanism of action is different. It's not just afferent versus efferent dilation or constriction. What this is reduction of inflammation and fibrosis, which is quite a different mechanism than any of the other therapies. Okay, well, let's see what happens. So Fidelio is taking Nirodone, 10 or 20 milligrams, placebo with kidney composite, time to kidney failure, 40% increase in estimated GFR from baseline, renal death, CBD composite. These studies all start looking alike because this outcome tends to work. What's different is the decline in kidney function. 40% is the less robust, 50 is a little more robust, and 57 is probably the most robust. These are mutations that were studied. This is the distribution. Most had UACR greater than 300. Most had estimated GFR less than 45. Definite reduction in albuminuria, which you also see with SGLT2 inhibitors. So with finerenone, unlike spironolactone, does not reduce blood pressure very much. So it would be very useful. The heart failure that your trial just reported out and the Endocrinology Society of Cardiology was also positive would be very useful to those patients who don't have a lot of blood pressure to give you. Okay? Change in A1C doesn't do that either. Fidelio primary endpoint, kidney failure, 40% decrease, eGFR, or with renal death, hazard ratio 0.82. Okay, so 28% or 18% risk reduction on top of ACE and ARB. And so this is what it looks like for a hazard ratio, all pretty consistent. Looks pretty good. Cardiovascular death, not fatal MI, not fatal stroke. Hazard ratio 0.86, 14% risk reduction. So consistent theme that drugs that are good for kidneys are also good for hearts. Okay? The major problem here is hyperkalemia, as you might expect. So there's guidance about how to adjust the dose between 10 and 20 milligrams. We tolerate potassium levels up to 5.5, a little bit higher. You don't start getting all excited at 5.2. Let it go to 5.5. Try not to test potassium right after breakfast. You know, you'll be chasing it forever. Get the potassium at least 4 hours after eating. Fasting is even better. So the less you want to chase potassium is around, don't do it right after they eat. I'm just voice an experience here. So we're doing the Find One trial now in type 1 diabetes because this is a therapy. It's not cause ketoacidosis. Shouldn't be good for type 1 diabetes. Okay, there were actually 2 studies. Figaro was cardiovascular, Fidelio was the kidney trial. Combined, they were designed so that they could be combined for patient-level meta-analysis. Figaro used this primary as a cardiovascular endpoint. Fidelio used primary kidney outcome, and then these two are the same. So there's pooled analysis. And in the pooled analysis, we now have quite a broad group of patients with a broad range of kidney function. And the studies are structured the same. So this is composite cardiovascular outcome, hazard ratio 0.86, composite kidney outcome. So now we use a more robust, not the 40%, but 57%. So this is double. It's very robust kidney outcome because they're bigger numbers. Hazard ratio 0.77. So 23% risk reduction using the finerenone. Okay. That's what we see over here. Hazard ratio for heart failure, 0.78. Looks similar to SGLT2 inhibitors. Cardiovascular composite, 0.86. Hyperkalemia is a problem. There's guidance for checking potassium at a month, 3 months, adjusting the dose if need be, lower potassium diet, putting in diet, all the usual stuff. Okay? So benefit risk, much less hyperkalemia than VA-nephron with dual RAS blockade. This is 10% versus 2.3%. Also, altitude was the Illustrate study. About 5% caused early termination of that study. So compared to the dual RAS blockade, we see less hyperkalemia, also compared to spironolactone. So this is spironolactone, ACR 3 versus 2.3% at 12 weeks. Okay, so you're thinking, well, why don't we just use spironolactone? And that is potentially an option. And is an option particularly for patients with somewhat resistant hypertension. There's still hypertension, there are 2 or 3 agents. You might want to try spironolactone. What's the difference between these two? So spironolactone and finerenone are flat, they're steroidal. Finerenone is bulky, but potency to mineral-hormone receptor, strongly positive with spironolactone, less so with finerenone, strongly positive with finerenone. Selectivity, though, is the greatest with finerenone. CNS penetration does not occur with finerenone, so side effects are less. There are no sexual side effects. So men who've developed and advanced yourself kind of too late at that point will not have that problem on finerenone. So spironolactone also has a very long half-life. You can't just stop it and have the potassium come down. It's on board for days, and it has active metabolites. So you have to be fairly careful using spironolactone in patients with the potassium problems. You can stop Finerenone and you'll see a change in nature. Okay? Effect on blood pressure, much more pronounced with spironolactone, as we've learned as we've identified, not so much with Finerenone. So they're different. There is no data in spironolactone to about any outcomes. There's some presumed data for heart failure, so on the pillars of therapy. So we now have pillars of therapy for prevention of progression of diabetic kidney disease. Those pillars include RAS blockade, use the highest dose that you can use. Don't stop it. SGLT2 inhibitors, I do not have to use the highest dose. So 10 of GABA, 10 of EMPA, 100 of CANA, you do not have to use the highest dose. In fact, doesn't seem to matter very much. MR antagonism, Finerenone 10 or 20, and GLP-1 agonism, current best data is with ozempic, but we also have data with dulaglutide, and we will be getting data with tirzepatide. And, the durable continues kind of, lots of fun. KDIGO is now behind. It's, when you're a couple years behind, you don't capture the recent studies. SGLT2 inhibitors should be used in everybody. Metformin, okay, it's not a bad idea, but it's not critical either. RAS at maximum tolerated dose, cardiovascular risk reduction, and then GLP-1 receptor antagonist. This was 2022 before the flow trial was announced. Non-steroidal mineralocorticoid receptor antagonism and other glucose-lowering drugs. I mean, most of us would say, look, if these patients should already have their A1C controlled, but if not, just get started. Okay, to summarize, prevention of progression of diabetic kidney disease requires a multi-pronged, now a pillared approach. And what does a pillared approach imply? It implies that patients should be on all of these therapies. Not pick your favorite, not SGLT2 inhibitor, I'm done. They need maximum protection. And what's interesting is these are working together fairly well. They have drug interactions. Glucose control is most effective early, but there's some data that even after patients develop kidney disease, it's still worth doing. Blood pressure control to less than 130/80. GLP-1 receptor agonist gives you cardiovascular and kidney protection. SGLT2 inhibitor has the strongest data overall, the biggest risk reduction for persons with or without diabetes or with albuminuria. It does not work. We just don't without albuminuria. So what to do with that patient with anemia or 49 without albuminuria? There's still, I have some questions. Finerenone and mineralocorticoid receptor antagonist provides additional cardiorenal benefits and protection across a very wide range of kidney function. So, there you go. Thank you very much.